Hi, everyone. My name is Lily, and I'm the Billing and Office Manager here at Community Health Resource Center. Thank you for joining us for our first session of our Chronic Kidney Disease and Nutrition series this year. Today's presentation will start with an overview of chronic kidney disease, covering the 5 stages, causes, and key risk factors. In the second half of today's session, we have CPMC Director, Advanced Organ Therapies Metabolic Health Program, Dr. Nisha Patel here to discuss the role of GLP-1 receptor agonists in CKD management, how these medications impact patients with co-occurring conditions like diabetes, obesity, or cardiovascular disease, as well as nutrition considerations for those taking the drugs. I'd like to thank our partner, the National Kidney Foundation, for helping make this series possible. Before we get started, I'd like to share, there we go. I'd like to share a little bit about our organization for those that have not joined our programs in the past. Community Health Resource Center is a nonprofit organization here in San Francisco. We were established nearly 40 years ago by doctors at California Pacific Medical Center to provide resources and care to supplement their work with patients and support their overall health and well-being. Today, we provide 4 main areas of service. Those are social work or behavioral health services, nutrition counseling, community health screenings, and health education. This series is a culmination of 2 of our areas of service, which are nutrition counseling and health education. We're excited to have one of our nutrition providers, Elena Zidaru, leading this series. Elena is a registered dietitian and the director of our nutrition team. She is passionate about working in the outpatient setting and supporting her clients achieve their health goals. She provides individual nutrition counseling for weight loss and disease prevention, but also provides nutrition therapy for people with various medical conditions such as cancer, diabetes, chronic kidney disease, gastrointestinal disorders, cystic fibrosis, and more. Elena also provides nutrition therapy for cancer patients going through chemotherapy at the Brian Hemming Cancer Care Center and radiation oncology at the CPMC Radiation Oncology Department on an as-needed basis. Her goal is to meet her clients where they are in terms of readiness to change and help them set goals that are realistic and achievable to promote self-efficacy in achieving health behavior change. As a reminder, the information provided in today's presentation is for educational purposes only and is not a substitute for professional medical advice. I would now like to pass it along to Doris Liu from National Kidney Foundation to introduce herself and share more about their organization.
Great, thank you so much. Let me just get my screen up and that look good? Great. Yeah. Okay, so thank you, Lily. My name is Doris Liu. I am the program manager for patient programs at the National Kidney Foundation. We are the office that serves the Western region, California, Nevada, Oregon, and Washington. And we are always excited to be partnering with CHRC in this kidney health education series. So at NKF, we are revolutionizing the fight against kidney disease, and we do that in 3 main ways. We are working to eliminate preventable kidney disease, accelerate innovation for the dignity of the patient experience, and dismantle structural inequities in kidney care. And just forward. Oh. So nutrition is a huge part of preventing kidney disease. And so a lot of what you will hear in this series is about what you can do because kidney disease is a silent disease. And so nutrition plays a huge part, and we want to get ahead of that. And so I also want to share a couple of resources that we have. We have a nutrition hub, and you can find that on our website at kidney.org/nutrition. We also have a lot of information and support, and KF Cares is, I often refer to as our patient helpline, but really it serves not only people with kidney disease, but also friends and family, care partners, those who are exploring living donation. This is the place to go for anybody who's looking for kidney health information. NKF Peers is our peer mentor program, and that is for anybody who wants to connect with somebody who has been there, who has been a patient, who has been a living donor and wants to if you are someone who wants to talk about that experience. It is also available in Spanish and available to those who are care partners and want to talk to people who have been part of that. Our online communities is a place to go to ask your questions anonymously and to hear what others say about their experience. So that is also another very valuable resource. We have a Kidney Learning Center where we provide kidney health information for patients, covering everything from the basics of chronic kidney disease to dialysis to transplant and beyond. Also available in Spanish. We, for those of you who happen to be in the Southern California area, we have a kidney walk coming up September 28th. For those in Northern California, we just had one in June. And so if you want more information, go visit kidneywalk.org to find the one nearest you. And our website is simplykidney.org. And if you go there, you can find the place at the bottom that shows, oh, I meant to go back one. To click on your profile. If you are a patient, click here, medical professional. We have information for whatever your connection to kidney disease is. In the patient portal, we have diet and nutrition information, kidney topics, transplant, and lots of other topics. In the Nutrition Hub, you can find a lot of information about recipes, foods, recipes depending on your stage of kidney disease, and good information there as well. We've been getting a lot of calls also about our president's big, beautiful bill and how that affects the kidney community. So we do have a kidney patient action guide. You will find the link to that in our chat, and we will share that. For those of you who are watching the recording, you can see the link on the bottom, but the best thing to do is to go to kidney.org/takeaction, and you can sign up for our monthly newsletter and get all the latest information on kidney policies and kidney advocacy news. And I want to just thank you to Sutter Health CPMC for supporting today's or this month's series, our 3-week series on nutrition and kidney health. So with that, I want to hand that back over to you, Lily.
Wonderful. Thanks, Doris. I think we're all ready to go. You can go ahead and take it away, Elena.
Yes, thank you so much. I will share my screen now. Just want to make sure everybody can see my screen. Welcome, everyone. I'm Elena. I'm one of the dietitians with Community Health Resource Center, and I'm very excited to be here with you. This is I believe the 7th year that we partnership with National Kidney Foundation. I've been doing this class series, and it started like a very small class, and it became this big webinar. I'm excited to see over 100 people present today, and it seems like it's been growing every year. So I'm very excited. So this class, for those that you never participated before, so we have 3 consecutive weeks. The first one I will share because the agenda for today, it's a little bit more. Yes, we're going to talk about kidneys and basic kidney function, the difference between acute and chronic kidney disease, stages of kidney disease, risk factors, and we're not going to talk that much about nutrition. So week 2 and 3 are going to be heavy with nutrition information, but for me, it's very important to know that, I mean, when I'm the patient, like I need to understand why I need to do something, and I'll do it. But if I understand why is that important for me, so I take the same approach with my patients, and I feel like if we understand better the disease or the organ that's involved in a disease, we're gonna be better at managing that disease, right? So I think we're gonna do this kidney overview, and then we're gonna have a special guest speaker, Dr. Nisha Patel, that will talk about the GLP-1 receptor agonist drugs and how that can impact CKD management. So we're going to go ahead and start. How do kidneys work in our bodies? So kidneys are basically, sorry about that. They're basically 2 bean-shaped organs that are below our rib cage. That's where they're located. And they are filtering about 120 to 150 quarts of blood every day. And they produce out of that 1 to 2 quarts of urine, which is basically waste and fluid, waste material and fluid mixed together. So they do that daily. That's a lot of work. That's a lot of filtration. Imagine 120, 150 basically liters of blood in just 1 to 2 liters of waste material. Everything else is recycled back into your body. So it's just absolutely amazing that the amount of work they do. And I have here a picture of how the kidneys kind of work, basic information. I'll try to break it down in an easy way, but hopefully clear enough for everyone to understand more about the kidneys. So our blood with oxygen is pumped from the heart and enters the kidneys through this red renal artery. And then basically within each kidney, we have 2 of them, as I mentioned. There are about couple of millions of nephrons, which are tiny filters, basically. And each nephron has a glomerulus, which is depicted here. And basically what that is a network of capillaries, which are tiny, tiny blood vessels where the blood will flow. And they do basically all that filtration. It's like a very dense sieve. This is how I like to picture it. And what it happens when the blood enters this filtration kind of system, the glomerulus, you know, a lot of blood will get filtered, and the small kind of molecules can be water, can be waste material like urea and other substances that get dissolved in your blood. They're gonna be kind of filtered and moving the tubules, which are those, you know, those loopy long tubules, and they turn into urine. You see around the tubules, you have this kind of more blood vessels that actually will remove more water and more other nutrients that maybe did not get filtered the first time around. But in the end, from the tubules, you're gonna collect in the ureter. So there are 2 of them from the left kidney, from the right kidney, and those ureters will kind of move the urine into your urinary bladder, where it's the storage for the urine to, you know, get there until we have a full bladder and we need to eliminate out of the body our urine. However, as I said, there's a lot of filtration happens. So a lot of bigger molecules like protein is an example of them, and other nutrients get filtered back into your blood. So they're not transformed into the waste material. So they go back and they move from the kidneys through this blue renal vein, and they go back to your blood, to your heart, to get oxygenated and kind of do the process again. So that happens multiple times a day. As I said, about 150 quarts of blood will be filtered. So in that first part, that's kind of what I described. But the second part of this kind of busy with a lot of words type of slide, we have some of the roles of the kidneys. So they're basically responsible for keeping your blood composition stable, keep the balance of electrolytes, sodium, potassium, phosphorus. You see those are going to be affected when kidneys are failing and are not filtering well, because kidneys cannot eliminate and retain too much of it. So electrolyte balance is maintained by kidneys. The kidneys also make some hormones, couple of them very important. One is involving blood pressure regulation called renin, and then the other one is involving the red blood cell production, erythropoietin. When people with kidney failure, they might have to take that hormone to not be anemic and be able still to produce red blood cells. Also activates vitamin D, which maintains, it's very important for your bones because adequate vitamin D is needed for the calcium to be absorbed properly in our body. So some very important functions that our kidneys, besides the filtering, they do all that work too. There are 2 kinds of kidney diseases: acute kidney disease, which happens sometimes the exposure may be a medication or a toxin, a poison, something that enters your body that can actually injure your kidney. And early detection and appropriate treatment is important. And this can be totally reversible. So people after an acute kidney injury, they could just snap back to their baseline eGFR, estimated glomerular filtration rate that we'll talk later. So basically they're normal kidney function. You can recover from it. There are cases in which, again, if it's not detected earlier and you don't get the proper treatment, it can cause permanent damage, and people will develop CKD, chronic kidney disease, from that acute injury. But it's important to know that acute kidney disease, it's reversible. The chronic kidney disease, unfortunately, is not. It's more a permanent damage of the kidneys, and it can be managed and slowed down. The progression of it can be slowed down with diet modification, lifestyle modifications, and can be managed, right? I always say, if you lose some kidney function, you could kind of keep it there. Your kidneys will still function. When we see more in the picture of the stages of chronic kidney disease, your kidneys are still going to be able to function. The idea is to not allow further progression. I also can tell you from my experience with my patients, when I see changes, right, in their lifestyle, the GFR can bounce back a little bit. It's not going to be reversed. Let's say you have a GFR of maybe 34, you could get to the 40s. Versus I don't see it happening, like you're not going to go into the 80s, 90s, or 100, right? So you're not reversing it, but you could improve it to some extent. And I've seen that happening before. The detection of kidney disease, how do we diagnose? How do we catch this? Well, there is the blood test, which you can test blood creatinine level, which usually goes up with damage of kidneys, and the estimated glomerular filtration rate. That's a formula that actually takes the creatinine into consideration, and it's basically an estimation of your glomerular filtration rate, this eGFR, and this one usually decreases as the function deteriorates. So basically they go kind of in opposite direction. If creatinine goes up and GFR goes low, that's the sign of, that kind of means CKD. And there are different stages based on those numbers, but both the creatinine and the GFR are part of the comprehensive metabolic panel, which is the CMP, which is classic annual screening type of lab that every doctor will order. So that's the good news. That's why I encourage my patients, just do annual labs, because you could catch this disease that's silent. We'll see that a lot of times, unless late stages, you really don't have symptoms to really know this is happening and you have CKD. The urine test also can be helpful. It tests the presence of protein and blood in your urine in healthy kidneys. In healthy people with healthy kidneys, you're not seeing blood or protein in the urine. But protein in the urine, even within a normal GFR, can indicate an increased risk of developing CKD. So it's very important, especially if you're high risk. That means having high blood pressure, or diabetes, or family history of CKD. You want to do this annual urine test, which is albumin creatinine ratio. And you should check that, as I said, annually if you're higher risk. As I mentioned, they're not really specific symptoms of CKD unless kidney disease is advanced, so late stages. You might notice, however, that you have less energy, trouble concentrating, poor appetite, trouble sleeping, some muscle cramping at night, or swollen feet and ankles. Some people, experience puffiness, especially around the eyes in the morning, dry, itchy skin, the need to urinate more often, especially at night. But, those actually symptoms are more, it could be other things, right? It's not that only CKD can lead to those. And as I said, happen usually later in the late stages, which we want to catch CKD in early stages to be able to manage better. So CKD, as I mentioned, gradual and progressive loss of kidney function over time. It's named the silent killer because it has mainly no symptoms in early stages. Now, high blood pressure and diabetes are the main causes of CKD. And almost half of the individuals with CKD also have diabetes and or self-reported cardiovascular disease. So the managing, I could tell you from the beginning, and you'll hear this throughout my presentation, even the following weeks, managing blood sugar and blood pressure will be very important ways to take care of your kidneys. There might be other causes for CKD, like glomerulonephritis, which is kind of like an inflammation of those glomeruli. Inherited diseases like polycystic kidney disease or lupus, which is autoimmune disease. Obstructions caused by kidney stones or tumors or enlarged prostate gland in men, or repeated urinary tract infections. So those are, as I said, possible also conditions that increase risk of CKD, but the main ones will be diabetes and high blood pressures, not control. So uncontrolled diabetes and blood pressure. Stages of CKD, so they're based on eGFR. The eGFR, as I mentioned, is the rate at which the blood is filtered through the kidneys every minute. Of course, you have a slower, like a lower number, that means your kidneys are not really filtering as effectively your blood. It's calculated using a formula I mentioned. Blood creatinine is needed along other factors, and a normal GFR ranges from 90 to 120 mLs per minute. So basically 120 mLs of blood per minute. Those stages from 1 to 5. So stage 1 is basically normal kidney function, 90 or higher. As I said, it can be up to 120. Stage 2, it's kind of a mild loss of kidney function. So eGFR would be between 60 to 89, which translates into 60, 89 capacity of your kidneys. So your kidneys are working at the 60 to 89% capacity. Then we have stage 3A, which is considered mild to moderate loss of kidney function. 45 to 59 would be the GFR within those numbers. Stage 3B, moderate to severe loss of kidney function, which would have 30 to 44. Stage 4 is severe loss of kidney function, which is usually 15 to 29, so under 30. And then stage 5, which is considered kidney failure, less than 50% of your kidneys are working, which at this stage, usually people, prepare for dialysis or for kidney transplant. So it's important the way you could see, it's important to catch as early as possible the damage and try to slow down the progression, maintain your function. The way you see in those first stages, your kidneys can function pretty well with less capacity. So for the stage 5 CKD options, which we're not covering, so this presentation is mainly for prevention, right? Like addresses nutrition and changes for basically prevention and maintaining the kidney function. But at stage 5, the options would be hemodialysis, peritoneal dialysis, or kidney transplant. And I'm not going to address those, but basically the hemodialysis, you filter your blood, a machine kind of does that externally, takes over your kidneys. And then the peritoneal dialysis uses dialysate, which can be infused in your peritoneum, in your abdominal cavity, and that how the blood gets filtered through this dialysate. Risk factors for CKD, they're controllable and non-controllable. I like to always focus on controllable, what we can do. Diabetes, high blood pressure, heart disease, obesity. So all those can be controlled, right? We can better manage our blood sugar, blood pressure. We can lose weight. And then we have the non-controllable family history of CKD, age over 60, and race. Certain races are at higher risk of CKD than others. Very quickly, blood sugar control, as I said, is very important to really take care of your kidneys this way, control better your blood sugar if you have diabetes. How to manage blood sugar? You take the medications as prescribed by your doctor. A lot of diabetic patients will have to do a combination of lifestyle modifications and medications in order to be able to control better. Monitor as directed. A lot of times you need to monitor at home. Eat regularly, not have big gaps in between your meals, not eat too often, kind of grazing. You want to have about 3-4 hours in between your meals. Balance carbohydrates with protein, fats, and fibers. So even sometimes a healthy carbohydrate like a whole grain or a piece of fruit, it would be better to eat it with a little bit of protein and fat to slow down the absorption of that sugar. So have a handful of nuts with that piece of fruit. That would actually impact positively your blood sugar and not allow it to spike that much. Choose whole grains when possible. Again, more fiber would be better because it slows down that absorption of sugar. And it basically helps you digest at a slower rate, the carbohydrate. Limit the refined carbohydrates and simple sugars. Those are the ones that spike the most our blood sugar. So by limiting and not having as much, by also pairing them with other foods and eating them in a safe way and in a small amount when we still eat them would be important. Exercise regularly. When we contract our muscles, guess what happens? Your blood sugar drops because your muscle cells will have the ability to get that sugar from your blood to use it as fuel. So exercise will always lower your blood sugar. And control the amount of carbohydrate consumed in each meal. So it's better to have kind of small amounts of carbs spread throughout the day versus I'm not eating any carbs and then I'm binging on carbs. So that restriction binging kind of cycle that sometimes I see in my clients is not really helpful for your blood sugar regulation. So trying to kind of have a moderate approach and spread those carbohydrates in small amounts throughout your meals and snacks. How you manage blood pressure? You know, for the goal for CKD would be less than 130/80. For the systolic, diastolic blood pressure, how you manage, you take your medications as prescribed, you check your blood pressure regularly. A lot of times you might have to do that at home until you feel like you have a good control of it. Exercise regularly. Exercise drops blood pressure too. Manage stress. Stress can increase for sure blood pressure. Lose weight if overweight. It's a direct correlation between weight and blood pressure. I see it all the time. When people lose weight, the blood pressure drops. Reduce sodium in your diet. From a diet perspective, this is very important. So we recommend DASH dietary approaches to stop hypertension. You'll hear more in the following weeks about it. But basically, it's a diet with less sodium, so less processed food, more whole foods, less saturated fat and sugar, and more fruits, vegetables, legumes, whole grains, nuts, and seeds. So those plant-based whole foods. And when you lower the sodium and increase the potassium through those fruits, vegetables, legumes, you actually, this is kind of the best approach to manage your blood pressure from a diet perspective. Ways to prevent and manage CKD. You want to increase your physical activity as tolerated. Some people may need PT guidance. You want to limit your sodium, and that's good for blood pressure, but also just for CKD, let's say for someone that doesn't have high blood pressure. Control blood sugar, blood pressure, as I mentioned, and you're going to keep hearing about because I can't emphasize how important it is. Quit smoking if you're smoking and reduce alcohol consumption if you drink. We have here no more than a drink a day as a female and no more than 2 drinks a day if you're a man. Lose weight if overweight, and modifying diet, more to come, as I said, next week and the following weeks, so in week 2 and 3. This is just to say the maintenance nutrition therapy has a role in slowing the progression of CKD. It's been proven, and you know, all the changes you make from a diet perspective and lifestyle perspective will make a difference in your health. There's some nutrients of concern: sodium, phosphorus, potassium, protein, fluids, and we'll talk more in detail next week because they're also based on different stages of CKD. So I don't want to take more time because I know Dr. Patel is here, and I emphasize how important weight management is as CKD and managing blood sugar and blood pressure, and she'll talk more about that with you. Thank you so much. And I'll see you all next week at 3:30.
Thanks, Elena. Welcome, Dr. Patel.
All right. Well, very nice to meet everybody here. I'm Dr. Nisha Patel, and I have the privilege of being our medical director of our transplant metabolic health program here at California Pacific Medical Center at Sutter Health. And I'm really excited to talk about weight management and chronic kidney disease and transplant. It's a very important topic. You know, what's amazing is that there's more and more recognition on the benefits of weight management for patients with chronic kidney disease, and especially after transplant. You'll learn a little bit more on why that's important. So I'll dive right in. I've got a lot that I want to say and cover. I have no disclosure or conflicts of interest. I am going to talk about medications, but I don't have any affiliations with the pharmaceutical companies that are making those particular medications, but they are tools that I use for my patients. So I'll talk a little bit more about what's the link between chronic kidney disease and obesity, talk a little bit about what is GLP-1 and why do we care about it, and what's the role of using GLP-1 receptor agonist class of medications in patients with obesity and chronic kidney disease, and talk a little bit about treatments in the pipeline, and also touch on some lifestyle factors that are really important to consider when you're thinking about using one of these medications. So I always start off with a quote from my patient. I can't tell you how many times I've had patients tell me something similar, like, is this what it's like to feel normal? Is this what it's like to, eat healthier without having to feel like you're constantly battling what's called food noise? And so this was a particular quote from a patient on Wegovy, or also known as semaglutide. I always start off any of my talks on weight management and obesity to say that we really should use people first language, even in our conversations amongst each other. Oftentimes we'll say that, the woman was obese, or that person that's an obese person, but in reality, people are not defined by what their disease is. We don't say chronic kidney disease person, so we say woman with obesity or person with obesity. It's really important to use that information or that language when we're talking about the chronic disease of obesity. And, obesity is a chronic disease. It's when individuals have accumulated increased body fat, and that body fat actually is causing health problems. It's causing not only metabolic complications like chronic kidney disease and diabetes and heart disease, it could also cause biomechanical concerns, for example, osteoarthritis or knee pain. And so, we really think about treatment from a health standpoint. I always joke and I say this isn't about getting bikini body ready, and this isn't about, dropping 10 pounds to fit into jeans. Like, this is a medical condition, just like diabetes, just like chronic kidney disease, and we want to do everything that we can utilizing lifestyle and medical management to help. I won't get into too much detail about why obesity develops, but I do want people to understand that just like many diseases out there, whether it be diabetes or chronic kidney disease or heart disease, there's always this interplay between our own genetics and our biology and the environment that we live in, right? I think we can all appreciate that people with a family history of certain conditions are at higher risk of developing those conditions. Doesn't mean that genes are always our destiny, but unfortunately, we live in a very challenging environment. We're not sleeping very much. We're less physically active. Our food environment is extremely challenging to navigate. And so, diseases develop because of the combination of these different factors. And we know that our brain is actually the center of appetite regulation. Our brain is actually, I call it the master regulator of body fat levels. And people are often surprised to hear that because they think, weight is all in their control, but a lot of what's happening with our appetite signaling, our hunger, our fullness, our cravings, a lot of it's happening without us really even realizing it's happening. And we know that there's, person-to-person differences in how they experience that. A lot of the genetic differences that we talk about with weight management actually happen at the level of the brain. So not going into this, neurobiology of obesity, but just to understand that the brain is definitely a central part of it, and it's integrating signals from your body fat, from your gut, from other parts of your body, trying to really understand, how much body fat do I have? How much adiposity, which is the medical term for body fat. And it's this tug of war between, losing weight and weight gain. Anyone that's ever been on a weight management journey can understand that losing weight is hard, but keeping it off in the long term is even harder. And it's because your body is trying to fight between these different forces, and you can see these people are pulling on that tightrope. And really, this is to signify that there are, differences that tug and pull between hormones that increase appetite and hunger, or hormone, I should say, ghrelin, which is our main one, primarily made in the stomach, and our satiety or fullness hormones, which we have several of. Of course, GLP-1 is one of them, and we'll talk a little bit more. This is just to kind of illustrate the fact that, whenever individuals lose weight, your body starts to fight back by increasing appetite. It does also decrease your metabolism a little bit too. When you lose weight, you're not just losing body fat, you're also losing lean muscle mass. And, patients with chronic kidney disease, I always really emphasize the exercise piece of it, because that is one of the most prudent ways to, keep your lean muscle mass, which will help, raise how many calories you're burning. So you don't lose so much muscle from a weight management standpoint, and also because we don't want people to get frail over time, right? As we get older, we're at risk of developing more muscle loss. So there is a link between chronic kidney disease and obesity. Approximately 1 in 2 patients with chronic kidney disease has obesity. And obesity is an independent risk factor for developing type 2 diabetes and chronic kidney disease. And it contributes up to 50% of new cases of type 2 diabetes each year. And so there is a link. We don't, in my mind, I often view these conditions as a network that shares similar pathology or similar pathways of development. And you'll see why GLP-1 receptor agonist class of medications, like, we often think of Ozempic as the one, but there's different names to them, can be beneficial for all of these conditions, CKD, obesity with weight management, and diabetes. And before I kind of launch into the heart of the talk, I always want to emphasize that, yes, prevention of disease is incredibly important, but we do have to understand that once disease develops, the train's really left the station, and we need to really help our patients with appropriate treatment now. But I'm not trying to discount the role of prevention. If we can prevent diseases and complications, that's like critical, right? But it's hard to do that once things have already kind of set into place. So as far as overall management goals, when we're talking about weight management and CKD, we want to improve health and quality of life, and also body composition. So oftentimes we get fixated on BMI and weight as a target. And yes, those are metrics that we look at, but I'm going to tell you that BMI doesn't give us the whole picture, right? It's a mathematical calculation, based height and based on weight. But it doesn't tell me, okay, how much body fat does somebody have? How much lean muscle do they have? Where are they storing that body fat? Because we know that people that store body fat in the abdomen, especially when it's affecting or in and around their internal organs, like their pancreas, their liver, their kidneys, we know that type of body fat is particularly inflammatory, and it can cause a lot of problems for people. So there are people right now walking around with normal BMIs that have elevated body fat level, and it's causing the same metabolic diseases compared to somebody that might have a higher weight or a higher BMI. So again, it doesn't give us the whole picture. In my office, we have this machine called the InBody, which looks at body composition. So what it helps me understand is, how much body water does somebody, did somebody say something? How much body water does somebody have? How much lean muscle mass do they have, or lean mass, I should say, have, and then what their body fat percentages and what's their distribution of body fat throughout their body. So let's talk a little bit about GLP-1, or also known as glucagon-like peptide 1. So what is GLP-1? Well, this is a hormone that our body makes every time we eat. And it's made primarily from our gut. Our brain also makes them GLP-1 as well. And it has a whole host of different effects depending on what type of organ system we're talking about. So we know that, unfortunately, our own GLP-1 doesn't last that long. You're going to probably see all these advertisements on social media about, GLP-1 cookies or GLP-1 oatmeal. And it's funny, it's almost laughable, because you're like, wait, we release GLP-1 when we eat, but ours gets broken down really fast, like within minutes. And so, we are not able to have the same effect from GLP-1 as taking a medication, a GLP-1 receptor agonist. But you can see, it has effects on the kidney. It actually improves, release of water and sodium or salt. It improves potentially inflammation. This is being studied in some autoimmune conditions. It improves fat deposition in the liver, so it can improve what's called fatty liver disease, or now called MASLD. Of course, it helps patients with diabetes, and then it primarily works in the brain when it comes to the weight management piece of it, because again, it's working on those appetite centers. We also think that there could be some direct and indirect effects on our kidney from GLP-1 receptor agonists that decrease inflammation. We know that when you lose weight, it does improve your blood pressure, which is, of course, going to be better for your kidneys overall if you have high blood pressure. It can maybe improve lipids or high cholesterol as well, and reduce insulin resistance and high blood sugar, which will hopefully take a load off your kidney. GLP-1 receptor agonists have been a part of diabetes guidelines for a very long time. It kind of, social media and the media kind of make it sound like these medications popped up overnight, but the class, I should say, GLP-1 receptor agonist, has been around since 2005. So this is not our first rodeo with this class of medications. Of course, there are newer medications that have popped up in the last several years, but again, this is not like new. Patients with diabetes have been prescribed them for a very long time. We know that in patients with diabetes, GLP-1 receptor agonists reduce the risk of heart disease. We now, and I'm going to go over the study, but have evidence that it slows down the progression of chronic kidney disease and albuminuria, which is that protein spillage in the urine that people experience, which makes us kind of more aware of that the kidneys are experiencing inflammation. And of course, it helps their diabetes. I do want to go over some nomenclature because I think a lot of times we use some of these names interchangeably, but I think it's important to understand that our insurance companies, unfortunately, view medications in a certain class for a certain disease process. So, for example, I often explain to patients that Wegovy and Ozempic are practically twin sisters. There's a little bit of minor differences in dosing, but in an insurance company's mind, Ozempic is used for diabetes, while Wegovy is used strictly for weight management, which is oftentimes why we can't, sometimes patients will message me and say, oh, well, my insurance doesn't cover Wegovy, but they cover Ozempic. I'm like, well, they cover it if you have diabetes and you don't. Even though, again, it's the same medication, it's really viewed as, treatments for two separate diseases, even though it's same thing with Zepbound and Mounjaro. So Zepbound is the weight management equivalent, and Mounjaro is the diabetes equivalent. That one is called tirzepatide, while Ozempic and Wegovy are called semaglutide. Tirzepatide is, I always call it as like a cousin of semaglutide. It shares some DNA, but it's a little bit different. But again, from insurance purposes, they do view Zepbound for weight management and Mounjaro for diabetes. What's interesting is that oftentimes people kind of equate in their mind like Ozempic or Mounjaro or Zepbound or Wegovy are like the first time a GLP-1 receptor agonist has ever been approved for weight management. And that's actually not true. In 2013, a medication called Saxenda, which was a daily injection compared to weekly injections, was actually approved for weight management. It just doesn't work as well as these others, so it's really not used that often. And then Saxenda has its diabetes counterpart called Victoza. So again, I just put that up there to be complete, but to understand that our primary tools that we use for patients with CKD are either Zepbound and Wegovy in the weight management world, or if they happen to have diabetes, we use Ozempic and Mounjaro. I will say that it's important to know that patients with diabetes, they don't tend to lose as much weight as somebody without diabetes, and that has actually been seen in clinical trials. That doesn't mean that the person's doing something wrong or they're failing. It's just that we know that maybe it's the underlying insulin resistance or other factors that they just tend not to have as much weight loss compared to somebody taking the same medication that didn't have diabetes. On average, these medications in clinical trials result in like 15 to 22% of total body weight loss. There's a lot of individual variability, meaning, you're not the same as this person and you're not the same as this person. And so there could be a lot of variability in how much weight somebody loses. Most people lose some degree of weight. Some people are, at the average. Some people are less than average. Some people are way more than average. And then there's some people that don't lose weight with this medication class. And it's not their fault. There's just some other factors that we don't quite understand as a medical community yet that really, make it more difficult for them to have a response to the medication. So I did want to talk a little bit about this primary trial that looked at semaglutide, also known as Ozempic, in patients with chronic kidney disease and type 2 diabetes. This was a fairly large study. They looked at almost 3,500 participants with diabetes and varying stages of chronic kidney disease with albuminuria. And what they actually saw is that individuals that were on semaglutide or Ozempic actually had a lower risk of developing their first major adverse kidney event. And they actually saw a slowing of the total eGFR slope. So you can see that this is in the individuals on semaglutide, and they actually had, this is the eGFR, and this is the eGFR increasing. You can see that the slope is at the higher, and it's above the placebo line, meaning that they had more preservation of their kidney function over time compared to those individuals that had placebo. And this was at the 1 milligram dose of semaglutide or Ozempic. Now, we don't have that kind of study yet for patients on tirzepatide or Mounjaro or Zepbound, or Mounjaro on the diabetes world, I should say. But there was a study that did look at individuals that were taking tirzepatide on top of other medications, whether it be insulin or other medication comparators in these diabetes trials, and they actually saw some improvement in protein spillage into the urine. So you can see that all of those blue lines are on the left column favoring tirzepatide. So they did see improvements there. And we also see that. I actually, this was in a patient with type 1 diabetes who's young, but, and again, these medications have not been studied in patients with type 1 diabetes, but we know that patients with type 1 diabetes develop chronic kidney disease. And it's really remarkable because we've seen like slowing of their, or like kind of improvement in their creatinine, which was very exciting. They have also looked at, there's some data to suggest that in patients without diabetes, so again, these are just patients maybe with obesity and other high blood pressure, other medical conditions, they don't have diabetes, that they might also have some benefits in taking a medication like semaglutide. So this was a big trial called the SELECT trial that was done primarily to look at heart disease outcomes. We do know that patients with a history of heart disease and obesity minus the diabetes actually had improvement or reduced risk of developing another heart attack, stroke, or peripheral artery disease complication. So they took some data from that big study and they looked at kidney outcomes. And they did see that there was a lower risk of developing a kidney composite event or probability of developing a kidney event in patients on semaglutide. So that's that blue line. So it's a lower probability. So this is what they were looking at, this 5-component kidney composite event endpoint. And I share this not to like get into the weeds about the data, but just to understand that, we are getting more and more data. And this is a common question that I get from patients, like, what's the data show? Like, how do I know this is going to help me? But, we are trying to collect that data or get that data. So they also saw that when they broke down these 5 components, some of the effects of improvement went away, but they also saw that there was still, some benefit or trend towards benefit of improvements in that protein spillage, which is really important, right? It's not just about the eGFR or the creatinine number. It's also about, are you spilling protein? Because there could be people out there with really mild CKD, CKD stage 2, but they're spilling a lot of protein, and that's still really bad place to be in. Again, there's a lot that we can do, so I'm not trying to say that to scare anybody or fearmonger, but just understand that protein spillage is also something that's very important that we need to look at because it tells us that there's inflammation that's affecting the kidney. There is a study that's ongoing looking at patients with obesity without diabetes on semaglutide, and they're also looking at reduction in that protein spillage. So this is what we call a primary study, meaning that the study is being designed to look at the specific question, does taking semaglutide do patients with obesity who have CKD or albuminuria while they're taking or have improvement in this when they're taking semaglutide? I'm not asking the question very good, but this is a study that's ongoing. So we don't have that data yet. So let's talk a little bit about role of GLP-1 receptor agonists in patients who received a kidney transplant. So, one of the challenges is that patients that have received a kidney transplant or transplant patients in general are often not included in these primary clinical trials. Oftentimes it's an exclusionary criteria, but we do use these medications in patients pre and post-transplant. So I always want to kind of talk about, why is obesity a problem in the transplant population? Well, we know that there's increased risk of surgical complications, a potential for reduced graft survival, possible, difficulties with dosing immunosuppression, limited access to transplant, depending on the center and the techniques that they're using. If individuals are carrying more body fat in their belly, it can make the transplant very technically challenging, and they may not be able to get transplanted until they lose some weight. And that's exactly what my program does to help our patients here at CPMC. We know that patients after transplant are at higher risk of developing what we call cardiometabolic diseases like diabetes, heart disease, even recurrent CKD in their transplanted kidneys. So it's really important for us to be proactive about trying to lower the risk of these conditions. Medication options might be limited. There are other non-GLP-1 medications that we use for weight management. We just can't use them in patients with chronic kidney disease, especially advanced chronic kidney disease, because it's not safe to do so. So we do know that, why do patients gain weight or develop these metabolic complications after transplant? It can be because they have pre-existing obesity with what's called sarcopenia. So sarcopenia is this medical term for having low muscle mass and function. And unfortunately, a lot of people out there have that in addition to having excess body fat. And that particularly is problematic. Many of our patients pre-transplant have that as well. And so if they already are going into transplant with sarcopenic obesity, then they're at risk of developing further complications. We know that the immunosuppression that patients are on can really increase their risk of developing complications like diabetes, heart disease, or high cholesterol, high blood pressure, I should say. And then people feel better, after transplant too, so their appetite increases. There could be some genetic factors. So there's a lot there's a lot to consider when we're talking about risk post-transplant. Again, this is just to illustrate the fact that these steroids, these calcineurin inhibitors like tacrolimus, other immunosuppressive agents called mTOR inhibitors that are used most often, can cause high blood pressure, problems with blood sugar, cholesterol, and more. So these are things that we have to think about. Now, there was a study that was published by one of my colleagues at NYU. His team looked at individuals that had received a kidney transplant and had Medicare, and within 6 months of post-transplant, this was a pretty large study. I think they had almost 4,000 individuals or charts, I should say, that they reviewed. And individuals that received a GLP-1 receptor agonist, for example, Ozempic, or what else was that they looked at? Trulicity is another one that's often used. And again, these patients have pre-existing diabetes. Those patients that had a GLP-1 receptor agonist use within the first 6 months of being post-transplant actually had, improvements in graft survival, which is really interesting. And so I think that, or I should say, unadjusted cumulative incidence of death-centered graft loss, so graft survival, they had a lower risk, I should say, of developing that. So that was really interesting. And I know that his center is really looking into the kidney transplant population and really wanting to publish that data. So GLP-1 receptor agonist used in people on dialysis. So again, data is very limited, but this is where centers like mine are really hoping to add to the breadth of knowledge and data and research out there to help people understand that, we can use these medications in patients on dialysis with some important considerations. I also want to highlight that there are medications that are in the pipeline. It's not just the ones that I showed you earlier. There's others that are in the pipeline right now that are being studied, and hopefully in the next, 2 to 5 years, we'll have more options, including an oral option, like a pill option. And I suspect, unless there's something really specific to be said, that hopefully these will also be, prescribed in patients with chronic kidney disease, or we can prescribe them, I should say. So we have to understand that there are barriers, unfortunately, to, acquiring these medications or getting these medications covered. Insurance and cost are a really big barrier. Oftentimes for patients with diabetes, it's not as much of a barrier as those without diabetes. And so, that is something that we have to think about. Sometimes patients are afraid or they've heard things on the internet, the side effects like, I don't want to be on that. That causes stomach paralysis. I read this online, and, oftentimes a lot of what I'm doing in clinic is trying to, undo some of the bad information. No medication is without its risk, right? It's always a risk-benefit conversation. But in most of my patients, utilizing this medication class has a lot more benefits. And we follow our patients here longitudinally, and we really tailor the treatment and individualize it to their care. So those are things to think about. I want to talk a little bit about managing side effects. Side effects, again, are real with medications, and the most common ones we often see in patients taking like an Ozempic or GLP-1 receptor agonist is nausea and constipation. I always kind of joke and say, I don't want anyone vomiting. And there are things that we can do to really help mitigate the nausea, kind of reduce the risk of any vomiting, especially if they're getting used to the medication class. and constipation. Less often patients have diarrhea and abdominal discomfort or pain per se. But what I tell patients is that, like, think of like what your appetite and your eating habits are now, and just know that we're going to need to adjust those when you're on medication. So they're going into it understanding that this is going to be an adjustment for me, and I'm going to have to make some gradual changes to help myself with making sure I'm meeting my dietary needs and also tolerating the medication. There's 3 things that I tell patients all the time. I really don't want them to, drink alcohol, especially in the first couple of months, because, these medications, like, depending on the individual, may not go down very well with alcohol. And in general, we should all be limiting our alcohol intake, really avoiding, high-fat, greasy food, which in general, we don't, especially fast food, for example, we want to be mindful of and, not expose ourselves to it often. But, sometimes you go out for a birthday and have a couple of slices of pizza, and I tell them if you're going to do that, starting the medication, you should take a bite or two and see how you feel first before, trying to really eat that pizza. And the other thing is, when you feel full on these medications, it's not like you can actually, like, you have to stop eating, because if you try to push past the point of fullness on a medication, you're going to feel sick. And this is new to a lot of people, right? Because we've all a lot of us can push past the point of fullness if we're not on a GLP-1 receptor agonist class of medication. I always joke and say, we don't want to get Thanksgiving full on this class of medication. But even if patients try to, like, finish those last few bites of something that they're eating, if they overdo it, it does, it can, exacerbate the symptoms. Sometimes we want to think about making sure that we stay hydrated. This medication class affects your appetite, especially if chronic kidney disease and you're on diuretics and you're on all of these things. Like, we don't want you to get dehydrated. I do not want my patients on dialysis or chronic kidney disease developing vomiting and diarrhea and be at risk of getting, dehydrated potentially. So I always tell them, like, hey, I need to know about the side effects if you're having them. Setting timers to remind yourself to drink water, because again, your appetite and your eating is affected, and sometimes, water intake can decrease because of that. This is not the time to be adventurous with food. We really try to avoid certain foods that, especially like spicier foods in the beginning too, anything that could upset the kind of balance between your body getting used to the medication and you trying to meet your needs, your nutritional needs. There's some other information here, and I'm happy to share this with all of you, because I know I'm just watching the time to make sure that I don't go over. But I'm happy to share this with you. Of course, like I said, if anyone's vomiting, we definitely need to know about it so that we can really work on trying to first kind of treat the acute symptoms of vomiting, and then, think about what we do going forward. This is where that individualized dose titration comes into play. Like, in clinical trials, they increase the dose of the medication every 4 weeks, but we don't always do that, and we don't always need to do that. I like to keep my patients on the lowest dose that's working for them. And if patients are having side effects, we just go slower. And for most people, that actually helps their symptoms get better, and they do end up tolerating the medication over time. But this is what why we need to make sure that, you're on this medication class. It's coming from somebody that, feels comfortable managing patients with chronic kidney disease on this medication class or on dialysis. There's a lot of med spas and clinics and things out there that are just kind of giving prescriptions out without really thinking about who's in front of them. And I often tell my patients, like, hey, that's probably not the safest thing for you, and you really want to have, like, an appropriate individual managing it. So this is, again, some more guidance on dose escalation or de-escalation. One, to think about cutting back on the dose if patients are having side effects. When can we go up on the dose? But there's a lot of, like I said, inter-individual variation in it. I feel very comfortable prescribing it in patients with CKD and on dialysis, but that's, years of experience to really learn, like, what works, what doesn't work. And there's still a small subset of people where the medication side effects are too much, and that's okay. That's not their fault. That's just not the medication for them, and we got to think about other strategies. I know that you're going to have a lot more information on CKD and nutrition, so I'm not here to rehash all of that great information that you're going to get from Elena, but I do want to talk a little bit about some of the lifestyle things that I talk to patients about. Flexible thinking is really important. in weight management. You know, a lot of times the conversations around weight management are like, I ate a cookie and everything's gone to heck, and, you know, now what's the point? And that's really not how we need to view it. You know, like the rigid thinking that of I have to follow the plan exactly needs to become, okay, let's adjust and keep going, right? We need to have some flexibility here. And that term is actually called cognitive flexibility. And it helps you adapt to the day-to-day life instead of just like giving up or, you know, stopping the plan that you're trying to work on. Sleep is one of those things that people don't often think about with weight management, but I'll just tell you this, that a lot of our patients with chronic kidney disease have trouble sleeping, especially when they're on dialysis, whether it be because their dialysis start time is, you know, at 4 a.m. or 5 a.m. in the morning or 6 a.m. in the morning. That's really hard, right? Or if they're on peritoneal dialysis at night. So there's only so much there you can control, but you know, sleep is one of those things, as much as you can prioritize, we want you to prioritize it because it does impact your appetite and, you know, diabetes and heart disease risk and all of that. So it's one thing to, you know, there's things to consider. What's interesting is that the gold standard treatment for insomnia is actually not a medication. It's something called cognitive behavioral therapy for insomnia. Unfortunately, there's not a lot of CBTI therapists out there, but there are some really interesting apps that people can look into that I've just put there. And this is well supported in literature. Of course, exercise, especially strength training, is so important. I think a lot of times the conversations are about cardio. I need to do cardio, but people often forget that, yes, that's really important, and it's a great way to train our heart and a great way to improve our exercise tolerance. But we also want to add the muscle strengthening exercises because we don't want you to lose too much muscle when you're losing weight and also get frail over time. So here's some guidance on, you know, it's also known as, I call it strength training because that also involves, like, it's not just lifting, you know, dumbbells, but I think a lot of people know, remember it as resistance training. So those are often used interchangeably, I should say. Another aspect of physical activity that people often don't think about is all the movement that you do that's not exercise. So there's a term for that. It's called non-exercise activity thermogenesis. And the way I describe this to people is that, for example, if somebody went to the gym and they got onto the treadmill and for 30 minutes, you know, walked 2 miles and burned 250 calories, but then for the rest of the day, they just sat. They're actually going to burn maybe fewer calories than the individual that decided that they were going to move around constantly on their feet, running errands, going up and down the stairs, parking their car far away, vacuuming, unloading and loading the dishwasher, folding their clothes standing up. And let's say they did that for 8 hours throughout the day. They're probably going to burn more calories than that one person that did the 30 minutes on the treadmill. Now, I'm not saying you shouldn't exercise. Absolutely, exercise, very important. But I tell patients that, like, look, I don't want you sitting for the rest of the day either. And unfortunately, our patients on dialysis, you know, they have to go to dialysis and they are sitting a lot more. And so, you know, on the days that they're feeling better, usually on their non-dialysis days, I do encourage them to move. And your mental health is important. It's a core metabolic intervention. I often ask my patients about stressors and try to connect them with mental health professionals because it, you know, again, you know, dealing with chronic illness is very hard. And sometimes there's a lot of other personal stressors that are ongoing in the background, and it makes it harder, especially when patients find themselves, you know, eating more, using food to cope with emotion. And remember, you want to celebrate all of the wins without fixating on perfection. It's not about being perfect. There's no perfect person. I struggle the same way in a lot of ways that my patients struggle, right? Some days I'm like, I don't want to exercise. Some days it's hard to get to the gym, but I always remember that, hey, look, I feel great after I do it. So I lean into that feeling. Like, for example, after I'm done today, I've had meetings from 8 to 5:30 and saw patients in the morning as well. I'm not gonna be able to go to the gym, but I'm gonna do something in my home. Like, we have an exercise bike and I'm gonna get on it for 30 minutes because anything is better than nothing. And then you want to build your habits into the environment that you're already in with, or build health into the environment with micro habits. So, you know, if you forget to take your medications, it's like leaving your medication box next to the coffee pot, or leave your sneakers near the door to prompt walks or exercises. I'll tell you what I did today. My clothes for the exercise I'm going to do when I get home is like laying on my bed. So I'm going to walk in, I'm going to see it, we're going to change, and we're going to get on the bike. So remember, think flexible and stay consistent. Consistency isn't that exciting. I know. I wish there was a magic bullet or magic wand that I could like wave and everyone's health would get better or their weight would get better. But, you know, being consistent in all of those habits, no matter if they seem big or small, is super important. So key takeaways, I want everyone to remember that obesity is a chronic disease and that we really want to move treatment beyond just, you know, looking at BMI or weight. We want to improve our body composition through healthy eating, treating underlying, you know, the body, or improving body fat percentage and improving our lean muscle mass. And that these latest treatments that we use for weight management are not just weight management medications, right? Remember, they have a whole host of different effects potentially, you know, with improving heart disease risk, improving liver health, improving kidney disease, blood sugar. Like those are all things that come with taking medications like this. So I often kind of chuckle and joke that people call these weight loss medications. I get a little like, they're not just weight loss medications, but I get why people think that because that's how they've been perceived in the media. You know, we always want to use people first language, even when we're talking about ourselves, right? We're not defined by a disease, and that we know that obesity before and after transplant can increase the risk of developing complications. And it's important to know that, yes, we can use some of these GLP-1 receptor agonist medications in patients pre and post transplant with appropriate care and follow-up. So, all righty, that's the end of my talk.
Wonderful. Thank you, Dr. Patel. That was so informative. And we have lots of questions for you. So it looks like we've got plenty of time to go over those. I'm just going to share my screen here so everyone remembers where to put questions. Let's see. Okay. Here we go. Yeah, so if everyone can do their best to put their questions in the Q&A box, that'll help keep me organized in announcing questions, but I'll also do my best to keep an eye on the chat if any end up there. All right. Well, I know you went over the difference between the different GLP-1 receptor agonists. We have a question here asking about the difference. Do you mind just reviewing the difference between popular ones such as Ozempic, Mounjaro, and Wegovy?
Yeah, so Ozempic and Wegovy are both semaglutide, and Mounjaro and Zepbound are both tirzepatide. And I do like the cousin analogy because, you know, they share the DNA, but they are different. So technically, Ozempic works strictly on the GLP-1 receptor in our body, while I'm going to use semaglutide as the generic. Sorry, I'm not going to use the brand names right now. So semaglutide works strictly on the GLP-1 receptor, while tirzepatide actually works on two different receptors, and it mimics the action of two different gut hormones that we make. One of them is GLP-1, and the other one is GIP. We know that patients on tirzepatide tend to have less side effects, less nausea, kind of less queasiness compared to people just on semaglutide. So I'll tell you just off kind of based on my clinical experience, if patients' insurances cover the tirzepatide, I try to use that one over semaglutide because of the reduced risk of developing side effects. Some people are more sensitive to the straight GLP-1 activity that comes with semaglutide. We have receptors for GLP-1 in our brain, like in the vomiting center, and some people just happen to have more activity there. And so the tirzepatide actually doesn't work on that area as strongly, and that's why that's what we think, I should say, people tend to have less side effects. So for the purposes of like, you know, weight management and diabetes and what we call cardiometabolic health, both have, you know, number of benefits, although tirzepatide is newer, so a lot of those studies are still ongoing. But we do know that, for example, tirzepatide improved sleep apnea in a really interesting clinical trial. And so the FDA actually approved Zepbound or tirzepatide earlier this year for the treatment of sleep apnea in patients with obesity. So that was really exciting. So I think we're going to get more and more of those types of approvals, which will help hopefully improve insurance coverage.
Great. Thank you. And I see a question in the chat here. Wondering if you might be able to touch a little bit on the popular advertising of getting the GLP-1 medications online. I think a lot of these are compounding pharmacies, and wondering if you can talk a little bit about that.
Yeah, the compounded versions of medications I do not recommend for my patients because they're not FDA approved. In fact, I can't vouch for the safety or efficacy of it. I mean, I know a lot of these companies are marketing it as an equivalent to like the actual kind of pharmaceutical made medications, but I don't know. We don't know. And that's not a risk that I'm willing to take in my patients, especially when they already have chronic kidney disease. A lot of times the medications could be tainted or compounded with other medications out there. There's been reports of like it being compounded with insulin, which is very dangerous if somebody's like, and I'm not saying in the US that I've heard, this is kind of more in Europe, but I just don't think it's a risk that's worth taking. And trust me, I understand the frustrations, and I never blame patients for even thinking about that option because the medications are expensive out of pocket and insurance doesn't cover them consistently. So I understand why it's a very attractive like thing to look at, but I will say that for most of our patients, we're able to figure something out. And so I don't use any compounded versions. And I think that the FDA is really cracking down, and I'm actually kind of surprised that the compounding pharmacies are still, I think there's just too many of them. And at this point, it's become like a wildfire.
Thank you for sharing that. I thought that might be a good one to start off with. Another question, can we combine GLP-1 drugs with Jardiance?
Yes, you can. So oftentimes with diabetes treatment, depending on how severe the diabetes is, you may need combination treatment, and that could include things like metformin, Jardiance, and GLP-1 receptor agonist. We're trying to get away from using like medications like glipizide or glyburide because those are actually weight promoting, just like insulin. Although insulin is a life-saving medication for those that need it. So what we like to do is use other medications that are either weight neutral or weight loss promoting to reduce that insulin requirement if patients are on high doses of insulin. So yeah, they can be combined.
Great, thank you. And for people with type 1 diabetes and stage 5 CKD, is low blood pressure a common thing? I'm currently on Zepbound and experience frequent low blood pressure. Is there anything that can be done besides just adding more salt to my diet?
Yeah, that's hard to know without knowing your entire history. I will say that we know that Zepbound or we know weight loss reduces blood pressure. And by reduces, I mean improves it. So if people are on multiple blood pressure medications, I'm always hounding them that they need to check their blood pressure. They need to check it because if they start to notice it's going down, we've got to, either talk to their nephrologist or the medications need to be cut back on. Even in patients that are normotensive, let's say they don't have high blood pressure, it still actually improves your blood pressure. But most people have, unless they've got other, most healthy people, I should say, can compensate for that lowering. If patients have, again, high blood pressure medications on board or other medications that are not necessarily for their blood pressure, but they're impacting their blood pressure, like we kind of want to look there first. Yeah, it's hard to know exactly, and since I don't know your history, I can't say for sure, but that's like an intentional effect of the medication. Weight loss helps blood pressure. We also think that there might be weight loss independent effects. So this is why people with high blood pressure really need to monitor their blood pressure because it could get better. And blood pressure is like one of those things we all know that it's not lower. The lower isn't always better, right?
Right. Thank you. Here's another one that I know you covered in the presentation, but if you don't mind just reminding everyone, are weight loss drugs safe for CKD patients?
I would say they are safe with appropriate management. Remember, we talked about some of the side effects. I don't want my patients with CKD stage 3 getting dehydrated and developing acute kidney injury because they're not taking enough water in, or they're vomiting or having diarrhea. So those are things that we have to think about. But we do know that in the absence of side effects, I don't have evidence right now that, if anything, I have evidence to the the benefit that patients, especially with diabetes, can have improvements in their CKD, and hopefully potentially prevent progression to end-stage renal failure with especially Ozempic, because that's where our strongest data is. But I do think that data is coming for tirzepatide. I'm sorry that I keep using the brand names and the generics. I meant semaglutide. We have stronger data, and then coming for tirzepatide.
Got it. Thank you. And similarly, are GLP-1 drugs safe for Alport syndrome patients?
That's a good question. I'm going to be honest. I don't have a patient with Alport syndrome on a GLP-1 receptor agonist. I think that, it's not been studied in patients with Alport syndrome. I don't, at least off the top of my head, see why not with appropriate follow-up, but I'd have to actually look and make sure that there's no obvious contraindication.
Thank you. And for the submitter of that question, NKF, National Kidney Foundation, also has a staff nephrologist who will kind of save any of these questions we're unsure about and have those answered directly by a nephrologist as well. Are there any long-term side effects of these weight loss medications?
Yeah, that's a good question. I think that there's a lot of kind of fear-mongering about side effects and in the media, but I think that there are some individuals where we do have to be careful. So anyone that has gastroparesis already from diabetes or another cause, we want to make sure that we to understand how severe the gastroparesis is, because if you give a GLP-1 receptor agonist on top of that, it further slows down their stomach emptying. So gastroparesis is when there's problems with the nervous system of your stomach or your gut, and it doesn't really work that well, and people can develop nausea and vomiting and all these other symptoms, and GLP-1 receptor agonists could make that worse. So that is one set of individuals that we have to be careful with, especially if they have diabetes and it's not controlled. I'm not aware of any I'm trying to think of anything that there's no black box warning on this medication class aside from the fact that you can't use it in patients with what's called medullary thyroid cancer, which is a very rare type of cancer that I've honestly never seen. We use it in cautions with patients with pancreatitis, just because their pancreas is seen inflammation before, and that really is a risk benefits conversation with your doctor. Medication class is so good that you can correct high blood sugar relatively quickly, and we know that if you do that, depending on how severe somebody's diabetes is, it can actually make their retinopathy worse. And that's not an Ozempic or a Mounjaro effect. It could be from insulin too. So in general, we don't want to drop somebody's A1C down too fast, especially if they have diabetic retinopathy. We might be more careful with dosing. I know that there's been some reports out there of people developing blindness, you've probably seen that. And I will say that we don't have, at least from the randomized controlled clinical trials, we don't have evidence that people have developed this rare cause of blindness. It just so happens that people with diabetes are already at higher risk of developing that kind of blindness, and they just also might happen to be on, Ozempic or a GLP-1. But it is something for us to pay attention to. I think this is where, we can't ignore certain questions that come up about long-term effects. We need to look into it and obviously have those conversations with our patients.
Great, that makes sense. Thank you. And kind of on the same note, is there an expected kind of timeline for the common GLP-1 side effects to last after starting the drugs?
So usually I see the side effects when we're starting the medication and we're going up on the dose. I will say that if patients are having side effects, they do tend to get better within a couple of months. And this is where that slow dose titration is going to be really important. So sometimes I leave patients on the same dose for 3 months and they're kind of itching to go up, and I'm no, we will wait. Because at the end of the day, my goal is to help you tolerate the medication, get as much benefit from it with as minimal of side effects. And sometimes that takes patience.
Great, thank you. And Elena, you're welcome to hop in on any of these questions as well. I know a lot of them are very GLP-1 focused.
Yeah.
Yeah, and I'm trying to answer online for the ones that I can answer more appropriately. Yes.
Perfect. Thank you. This next one, how do I balance diet for both CKD stage 3 and heart problems, specifically for an elderly patient?
I'll let Elena take that one.
Yeah, so well, there are a lot of overlaps, and we'll talk more next week about a CKD diet. Now, it will depend on your stage and if you have to do more restriction versus oftentimes in stages 3, A and B, we kind of recommend the plant-based diet, Mediterranean diet pattern, as you will see in my slides, which is basically a heart health diet. The animal protein is not the emphasis of the plate. It's kind of on a small side. It's a lot of fruits and vegetables and whole grains, so like good starches. They're really not that different actually when you look at and as I said, it will make more sense as we talk next week about even DASH, the dietary approaches to stop hypertension, which is a diet that's more used for heart disease and high blood pressure, but can be used for kidney disease. So a plant-based diet, which again does not mean to become vegan unless people choose to, it really refers to the percentage of plant-based foods on your plate. When you look at your plate, most of the meals you're eating, you want more than 50% plant-based foods. And that's kind of the basic definition. Within that place, that plant-based diet, it's a big umbrella because veganism is part of that when it's 100% plant-based, vegetarianism, pescatarian, if you're pescatarian, can be part of it. But I also see sometimes people being vegetarian, not eating on a plant-based diet. They might eat French fries and onion rings. And yes, you're technically a vegetarian, but does it mean you kind of eat on the plant-based diet? You might eat a lot of cheese and eggs, and fried foods and not the healthiest foods for your heart. So this plant-based diet, as I said, we'll talk about the ratio of nutrients, the kind of foods, and in the proportion you want to eat. And we will go over in the next couple of weeks. But there are lots of overlaps and can be healthy for heart and kidneys.
Great. Thanks, Elena. Next question, how does transplant-related diabetes affect kidney health?
Yeah, it's your transplanted kidney can also develop damage from post-transplant diabetes, right? So that high blood sugar can also cause damage to that kidney and cause chronic kidney disease, again, in the transplanted kidney. And so getting your blood sugar under a better control before transplant, if you have diabetes or if you develop post-transplant diabetes, really, really important. And unfortunately, again, because of the immunosuppression, a lot of people are at higher risk of developing post-transplant diabetes or having their existing diabetes worsen. And so more reason to get, those patients have obesity, treat the obesity before transplant to hopefully help them improve outcomes. And, that's something that we're following in our patient population. As people get transplanted, we're trying to look at their long-term outcomes compared to others that maybe didn't have their weight addressed or, their blood sugars improved.
Great, thank you. I have one last question. It's a follow-up to the side effects question. And for anyone whose question we have not answered, I will be saving all of these and will either pass those along to a nephrologist or answer them in a spreadsheet that will be shared at the end of the series. But this last question, does Ozempic or any of these GLP-1 weight loss medications have any known side effects for patients who have already had a kidney transplant?
I don't think that it's been studied to look at unique side effects in patients post-kidney transplant. I think we have that one study that, again, it was an observational study. It wasn't a clinical trial that looked at kind of a reduced risk, I should say, of death, sensor graft loss. I wouldn't expect it to be out of the realm of just the side effects in general for the general population taking the medication, but I do think, again, patients are on different medications post-transplant. If they're on insulin, we got to watch that blood sugar, because it's the same thing with high blood pressure, where if you develop low blood sugar because your diabetes is getting better, you definitely have to have that insulin cut back on. So those are considerations to think about, but I'm not aware of like any unique side effects to the post-transplant population.
Great. Thanks, Dr. Patel. Again, I really appreciate everyone for entering their questions. I know we only had just a little bit of time to answer them. I'm sure we could talk about this topic for hours, but just wanted to thank you all for joining us here at Community Health Resource Center and National Kidney Foundation for this presentation. Thank you to Dr. Patel for taking the time out of your busy schedule to present for us today, and thank you to Elena for leading this series. I hope everyone has a great evening. We will send a post-event survey out, and if you complete that survey, you'll be emailed a copy of Elena's presentation slides. But again, just thank you all for joining, and thanks to our presenters for your time.
See you all next week.
Sure.